Good morning, everyone. Thank you for joining the Provider Compliance Forum. We will get started about 5 after 10. Um, Today, we'll be asking you to type your questions in the Q&A chat pod, which you should be able to find at the bottom of your webinar screen. If you take your cursor and hover at the bottom, a black toolbar should appear. And again, we're using the Q&A chat pod in order to type your questions. We are not using the chat feature, just the Q&A pod. So you'll click in there and you can type your question to us, and we will try to answer your question throughout today's presentation. If we are unable to answer your question, we will be including it in a Q&A document that will be sent out after today's presentation at some point. So again, good morning and thank you for joining. We'll get started about 5 after 10. Good morning, everyone. Thank you for joining the Provider Compliance Forum. We will get started about 5 after 10, just to allow for participants to join. We appreciate your attendance today. Please use the Q&A pod at the bottom of your screen to ask your questions throughout today's presentation, and we will do our best to address those questions throughout. If we are unable to answer your question, we will address your question afterward in a Q&A document that will be sent out after today's training. Good morning, everyone. Thanks for joining the Provider Compliance Forum. We'll get started in about 2 minutes. We're just waiting as we're seeing the numbers climb. Some more participants. We want to be fair and let everybody get a chance to hear. So we'll get started a little bit after 10, about 10:05. We are using the chat or the Q&A pod at the bottom of your screen. So if you take your cursor and hover at the bottom of the webinar room where you see the PowerPoint displayed, you'll see a black toolbar show up, and on that black toolbar, you'll see a Q&A button, if you will, and you can click on that and type your question. We will do our best to address the questions throughout today's presentation as we get through the sections of the presentation. If we are unable to answer your question, we will be putting that in a Q&A document, and after this training today, at some point, that document will be sent along with some other materials. So thank you for your attendance today, and it looks like we'll get started in about 1 minute. Okay, good morning, everyone. Thank you for joining the Provider Compliance Forum. We appreciate your attendance today. We're going to ask you to type your question in the Q&A chat pod at the bottom of your screen. For those of you who've just joined, I'll repeat, if you take your cursor and you hover at the bottom of your webinar room where you see the PowerPoint displayed, a black toolbar will display. And in that toolbar will be a Q&A button. You can click on that and type your question, and we'll do our best to address those questions throughout today's presentation. If we are unable to answer your question through today's presentation, we will be putting that question onto a Q&A document, and we will be sending that along with some additional materials at some point after today's training. So thank you very much for joining, and I'm going to pass the torch over to Carly. Carly, you may begin.
Thank you, Amy, and good morning, everyone. Happy Friday to you. My name is Carly Schilling. I'm the compliance manager for Magellan Behavioral Health of Pennsylvania, and welcome to Magellan's 2021 Compliance Forum for our contracted PA Health Choices Medicaid providers. We're always pleased to get such a positive response from providers wanting to participate in this voluntary training. Compliance continues to be a big deal to all of you, and we appreciate the interest and commitment of our providers to be compliant with Pennsylvania Medicaid and Magellan guidelines. We do strive to be transparent with our provider network and make a commitment to provide all of the tools and resources we can to help protect the financial integrity of the MA program. And this is one of the core reasons why Magellan does sponsor a compliance-only training for providers at least annually. We take our roles as stewards and managers of Medicaid dollars seriously. We want MA dollars to be used appropriately and compliantly to render quality services. I do tend to mention this every year during our compliance training, but I will continue to say it. There's nothing more satisfying for Magellan's auditors than conducting a provider review and finding zero billing or documentation errors. I was actually recently in a small provider meeting, and a provider who had had some compliance challenges over the years had just completed a Magellan audit and was very proud to tell me that they had a 0% claims error rate. So it was extremely satisfying to not only hear that a provider had a successful audit, but just how proud they were with the accomplishment. All right, Amy can go to the next slide. I wanted to introduce our team that's here today. This is our designated PA Health Choices Compliance and Special Investigations Unit teams, the majority of which will be presenting today. So we have 3 SIU claims and compliance auditors that are dedicated to our PA Health Choices County contracts. They include Tina Davis, Patty Marth, and Andrew Searles. Despite the county designations that appear on this slide for the auditors, I will note that they're not exclusively assigned to those counties. Andrew primarily conducts auditing activities in the Southeast counties. Tina Davis primarily conducts audits with the Cambria County providers, and Patty Marth primarily works with our providers in Lehigh and Northampton counties, but there's also considerable overlap in the assigned counties and activities. So for example, on Magellan's data mining activities, provider self-reports, follow-ups from member service verification surveys, you may hear from any one of these staff. Holly McQuiggan will also be participating in today's training. She is our Senior Compliance Coordinator, and she supports all of our PA Health Choices counties. And we also have two members of our team listening in today. Diane Devine is our Senior SIU Investigator, and Tanya Pennington is the Manager of the Special Investigations Unit. Next slide, please. So before we get into our formal agenda, I do want to review just some basic housekeeping items. You can go to the next slide. As I mentioned a few minutes ago, today's training is part of our ongoing effort to ensure that we provide ongoing education and support to our provider network related to compliance, fraud, waste, and abuse. Many of our provider trainings are posted on our website, and the link to those resources is shown here on this slide. We will be updating this page in the near future to add some of our most recent trainings, including this one. Today's training is scheduled from 10 to 12, but we do not expect to take the full 2 hours. We do know how valuable your time is. So as Amy stated, the training is being recorded, and we will share the PowerPoint presentation, a link to the recording of the training, and the Q&A responses to all the registrants after today's training. All participants are muted today. So again, as Amy stated, please use the question and answer option through Zoom. And then at the end of every section, we will try to read through as many of the applicable questions as possible and provide answers live, and anything that we can't answer will be sent out following the training today. And we also hope to send a survey to participants following the training so that we can get feedback and ideas for future training. So please look for that survey. We appreciate any and all feedback that providers can give us. All right, now we're going to get into our agenda for today. Many of these items may look familiar. We do cover a lot of the same topics every year. However, in survey responses, we continue to get requests from providers to cover and address many of these areas. So, but we also do try to introduce some new concepts and suggestions every year to try and make the trainings as unique as possible. So first, we will talk about some positive results we have seen in our oversight of providers in the last year or so. We always think it's important to call attention to these, as providers may feel, you know, there's too much focus on the mistakes and not enough on the great work that all of you are doing. Next, we will talk about 2021 audit trends, as this is typically the #1 requested agenda item from providers. So it's basically a staple for our annual trainings. We will spend a good bit of time talking about telehealth and the regulatory suspensions that were recently extended. We'll talk about our 2022 audit plans and a review of the audit process. And then we'll talk about some confidentiality and consent to treat reminders. And then we'll go through some other compliance reminders, as well as a review of the resources and tools that are available to all of you. So that's our agenda for today. And with that, I am going to pass it over to Patty Marth, and she is gonna take it away with our first agenda item.
Hello, and thank you, Carly, for the introduction. At this time, we would like to give all you providers a round of applause. We know that remote auditing may not be ideal or has been easy, as doing on-site audits, especially during COVID, with other things going on. We want to thank you for your flexibility, patience, willingness to adapt. We are all in this together, and with collaboration, we have accomplished the audits that needed to be completed. So thank you again for your flexibility and your collaboration with us. Next slide. Now I want to take a few minutes and review some collective data from 2015 to present. As seen in the slides, the error rate is an average of the years of the audits. The claims error rates have decreased from 2019. In 2020 to present, many factors attribute to such as a fewer billing errors, and also the emergency declaration suspended many regulations, which led to errors in the past, such as treatment plan signatures. We will get more into depth of some of those error trends later on in the presentation. As you can also see, providers are scoring higher on the compliance plan audit, which is very positive. We started with an average in 2015 of 83.14 and have remained pretty steady in the low 90s, with 2019 being an exception, however, it was still in the high 80s. Thank you for taking compliance seriously in your agency. Next slide. Now I will review some best practices. Some of you already have these in place. First, compliance hotline information hanging on posters throughout your facility or a part of your company's intranet system. Include an assessment or quiz attached to all compliance trainings and set a minimum standard for passing. Also, use this throughout the year and not just one time. Establish a culture of compliance. Example, host an anti-fraud week. And also, this was a new question on our compliance survey, and for the majority of staff, they have rated their employers high in culture of compliance due to the standards and training and ethics, and being very high with their ethics. Require board of directors to complete an annual compliance training. No one should be exempt from completing the annual compliance training. Compliance is a standing agenda for all board meetings. An example would be minutes discussions from the compliance committee. Develop and publish an annual corporate compliance report. This practice upholds a provider's commitment to comply with Medicaid standards and regulations. Utilize a service verification process, random calls, letters to members, and or guardians to verify services were delivered. We are strongly encouraging providers to increase the service verification process, especially during telehealth sessions. The use of GPS technology on company-owned vehicles or iPads. This is very common now, especially since the majority of providers do have company iPads or tablet devices due to their electronic health record. Speaking of electronic health records, the system should deactivate shortcuts such as cutting and pasting from a prior note. Internal claims audits prior to the actual claims being billed is highly recommended. We cannot stress the importance of having a strong internal controls, not just billing the correct code, but also reviewing the documentation and ensuring the documentation supports the codes and units that are billed. Many providers like Magellan also have a peer review process in place. The more eyes on is the better. At this time, I will pass to Tina Davis to review audit trends.
Thank you, Patty. So the most overall common audit trends that we see are missing documentation. Missing documentation includes missing progress notes, missing encounter forms when that is applicable, and missing signatures. And this could be member and or staff if you are using the progress notes for member signatures as an encounter form. Another one is charging members for missed appointments, and just remember that this is not permissible. Minimum documentation standards are not always being met. These are clearly documented in the Magellan Provider Handbook Supplement. One of the biggest non-compliant areas is failure to document the start and end times on a session, which is a Magellan requirement for all services and all levels of care. Another trend is not including the credentials when staff are signing their documents. Many providers utilize electronic health records and have typed notes, while others still use notes that are handwritten and paper notes. When reviewing handwritten notes, legibility is often an issue. Utilization of the correct error procedure is another common trend that is seen. Changes to the document should be crossed out with one line and not scratched out, initialed, and dated. Providers must follow all applicable PA Medicaid regulations for which they are licensed, enrolled, and contracted. Treatment, as well as the treatment plan, should be entered into the record. Level of care specific regulations stipulate how often a treatment plan must be reviewed and updated and who needs to sign it. It varies by program, and providers are responsible for knowing the requirements. For example, outpatient mental health. The initial treatment plan is to be completed within 30 consecutive calendar days. In the past, it was 15 days, and that's recently been changed. And that's 30 days following the intake for the individual who continues to participate in the treatment process. A mental health professional or mental health worker under the supervision of a mental health professional shall complete an assessment and initial treatment plan. For mental health outpatient, treatment plans are to be updated every 180 days, and this is also a change that was not in the too distant past. They can be updated if more often if needed, if changes in goals need made, that kind of thing. Consult the regulations for each specific level of care. Adherence to Magellan's contract rate sheet refers to using the correct modifier combination for the services that were provided. All claims must be submitted in accordance with the provider's Magellan rate sheet. So it's a good idea to consult your rate sheet every now and again just to make sure everything is as it should be. Another trend in this category is billing under a service location that is not contracted, or it's just incorrect for the service that's being provided. So please remember that service location 02 is to be used when telehealth services are provided. Specific to electronic health records, we see some common trends, including signature timestamps that precede the end time of session, or a signature timestamp that conflicts with another session or activity. Billing for non-covered or non-compensable, non-billable services is also a trend that we see during audits. For example, travel and transportation is not a billable service for most levels of care. Correct place of service is important to verify prior to submitting claims, as is billing the correct service location in addition to the correct billing location. Oftentimes these are not the same. Next slide, please. Next slide, please. Thank you. Specifically, mental health outpatient audit trends. Duplicate progress notes and treatment plans. Patty mentioned earlier to not allow copy and paste. Copying and paste is something that continues to be a trend. Sometimes it's just a sentence or two, and sometimes it's entire sections from one progress note to another or one treatment plan to another. Updates and progress notes need to be documented from note to note and plan to plan, so they should not be a mirror image of one another. Another trend in mental health outpatient that we see is start and end times are not always included or do not always reflect the true time of service. Please reference MA Bulletin 99-97-06 and the Magellan Provider Handbook Supplement for Pennsylvania Health Choices. Time in and time out are a required component of documentation. Another trend that is seen for mental health outpatient is missing effective dates and signatures, both on the treatment plans. Be sure that each treatment plan has a beginning date as well as an end date, and that the plan is signed and dated by all team members that are required. Next slide, please. For drug and alcohol outpatient, the audit trends for this level of care. The biggest one is the DNA outpatient groups exceeding the maximum number of participants. The maximum number of participants is 10, and you can have 12 if you have an approved waiver. This is not the same as mental health outpatient, so keep that in mind. Providers must implement a sound tracking mechanism for group participation, including arrival and departure times, as well as structured breaks if this is occurring. This is to be individualized and must correlate to the billable units. Only face-to-face time is billable for all outpatient services. This tracking mechanism is important, especially for providers when conducting groups via telehealth. Ensure that all progress notes are individualized for group sessions, especially, and individual sessions as well. Next slide, please. All right, let's take a moment to talk about peer support and certified recovery service audit trends. The member must be present for the CPS to bill face-to-face or telehealth interactions with collateral contacts. The family's friends, the individual's family, friends, and service providers or other essential persons. So if the member is not either with you or on the call or Zoom meeting with you, you cannot bill for face-to-face. Services that are duplicative or overlapping in nature is an emerging trend in 2021. While the need for team meetings do arise from time to time, the documentation must justify the reason for the team meeting and document the role of each staff involved. Payment will not be made for the following: services that are purely recreational, social, or leisure in nature, or have no therapeutic or programmatic content. Administrative costs such as agency meetings, record keeping activities, and other non-direct services are not reimbursable. Time spent in traveling or transporting members is not directly reimbursable and must be separated out on the documentation. The time that is spent in travel and transportation is very important, and not just the length of time, but the specific times that were traveled and transported, so that it's easily discerned that you are not billing for travel or transportation. And lastly, text messages and social media correspondence is not billable. This may be used for appointment reminders and scheduling per provider policy, but cannot be considered billable time. Next slide, please. Case management services. Mental health targeted blended case management is permitted to round up and bill a full unit if the better part of a unit, which is 8 minutes or more, is provided. However, this does not hold true for DNA case management. Rounding is not permitted for DNA case management. Matrix and service plan updates are not always updated per the regulations. Signatures or verbal consent have also been missing from this level of care. Other common audit trends in case management is billing for services that are not incompensable or not reimbursable. These are billing for time spent waiting in a doctor's office, waiting on the phone, that kind of thing. This time does not reflect therapeutic or programmatic content. Also, leaving messages is not billable. Administrative costs, agency staff meeting and record keeping activities all fall under that umbrella. Billing for travel and or transportation, this time must be separated out on the progress note to clearly document that is not included in billable time. And that would mean the time, the actual time spent in transportation and not just the minutes spent in transportation. Will help identify that transportation or travel is not being billed for. And again, text messages and social media correspondence. Again, it could be used for appointment reminders per provider policy, but cannot be considered billable time. At this time, Andrew will now provide audit trends of additional levels of care.
Thank you, Tina. The first level of care that I will be going over is centers of excellence. The first trend noticed was non-compliance with documentation standards. Please reference the Magellan Provider Handbook link that is listed on this slide for more information on documentation standards. Also, please note that documentation standards apply to the following elements: treatment plans, progress notes, and the general member record. Another another trend that was seen for this level of care was documentation at discharge or lack thereof. When the member is discharged from the program, there should be supporting documentation to accompany this step in the process. Limited engagement with members. Face-to-face contact is required for this level of care at least once every 30 days, as well as within 30 days of intake. For example, a new client who presents at the Center of Excellence for an initial consultation, but does not receive any billable services during that appointment or subsequent to that appointment will not lead to a per member per month payment. Another trend seen was limited linkages to community support. One of the main service requirements for Centers of Excellence is to collaborate with community providers. The last trend that was seen was limited collaboration. Centers of Excellence should act as a central hub for care coordination as well as referrals. The COE should provide clinical expertise to the wider provider community in a hub and spoke model of care. The COE will participate in a learning network that will include COE operational implementation as well as complex-based learning. Next slide, please. I will now go over the trends for the federally qualified healthcare clinics, also known as FQHCs. Again, please reference the Magellan PA Health Choices Handbook Supplement for information on documentation standards, as that was one of the trends that was noticed for this level of care. Again, documentation at discharge. Similarly to Centers of Excellence, when a member is discharged from an FQHC, there should be discharge documentation that supports this rationale. Limited collaboration, there should be documented evidence in the record that the FQHC is working with other providers to transition the member so that they are receiving the appropriate treatment. Treatment planning. Although this is a transitionary level of care, treatment plans are still required to meet Magellan documentation standards. And the last trend seen for this level of care was, again, limited linkages to community support. Next slide, please. I will now go over the trends that we're seeing for the 24-hour level of care. The first one includes billing for dates of service when the member is not present. This includes things like home passes, therapeutic leave, and the member being seen in another facility or being transferred to another level of care or another program. The dates of service that are submitted for reimbursement should only be ones where the member was receiving treatment at the inpatient mental health facility. Another trend that was seen was billing for dates of service where the member did not receive any mental health treatment for that entire day. As a reminder, it is not permissible to submit claims for reimbursement where the member did not receive any therapeutic treatment. In regards to clear and concise documentation, although this is a particularly in-depth level of care, all parts of the record must meet the documentation standard of being legible throughout. We are not able to accurately assess if the provider is adhering to the compliance standards if the record is comprised of handwritten notes that are unable to be easily read and/or understood. Documentation should also contain printed clinician name with credentials in addition to the clinician's signature with credentials. This is so that we are able to accurately determine which clinician is providing treatment for a particular date of service. Daily progress notes must support reimbursement by providing details of how a certain day of treatment transpired for the member. This includes things as the interventions that were used, as well as the member's response to treatment, how the aforementioned treatment related to the treatment plan goals. Progress notes that do not contain the appropriate amount of detail to support the time spent with the member would not be considered sufficient. For additional information, please reference Magellan's compliance email blast that covers this topic, that covers this level of care, that was sent out in March of 2020. Next slide, please. I will now cover trends that were seen in compliance programs. Policy and procedures for internal claims audits should contain the following information, and this was not always the case. Policy and procedures for internal claims audits should contain evidence of the internal claims audits being conducted, how often they are being conducted, for example, whether it's on a quarterly or semi-annual basis, and then lastly, what is the process for when claims discrepancies are identified. Reviews of the code of conduct as well as the compliance policy should be updated on an at least an annual basis. This is so that the code of conduct and compliance policies are reflective of the current guidelines and regulations. The last trend noticed was compliance being an element of the employee's evaluation. This is to say that is employee adherence to the agency's compliance policy being considered when it comes to things like promotions and merit increases. And then the last trend noted was when to have the investigation performed by an outside independent investigator. And this relates to the larger trend of the policy and procedure for responding to and reporting of compliance concerns. Additional elements that should go into this policy and procedure include a plan that addresses how internal investigation should be conducted, a time limit for closing a compliance investigation, as I stated just before, when to have an investigation performed by an external independent investigator, and lastly, reporting internal investigative findings to the state as well as the behavioral health managed care organization. Next slide, please. I will now cover trends that were noticed via the compliance surveys that were completed by employees of the providers that were audited. Employees should have knowledge of external resources to which they can report fraud, waste, and abuse. Examples of these external entities include, but are not limited to, Magellan's compliance department, county offices, and state regulatory agencies. Employees should also be aware of legal consequences of fraud, waste, and abuse. This includes understanding that partaking in FWA can have significant legal consequences, including fines and incarceration. Other trends that were noted for include being aware of who the agency's compliance officer was, not completing the entire survey, and understanding what collaborative documentation is. Next slide, please. I will now cover telehealth audit trends. Although the treatment is being provided in an alternative fashion, adherence to all other regulations and requirements still apply to this service being delivered as they would when it's being delivered in a face-to-face model. Unit definition and description for programs that are reimbursed on a fee-for-service model should continue to be accurately reflected in the claims that are billed. As a reminder, rounding up is not permitted. Services provided via telehealth should still be provided in a manner that is consistently aligned with the member's treatment or recovery plan. Other elements to keep in mind when utilizing telehealth include the following. The documentation must indicate the mechanisms for how the services were provided, whether it was through telehealth, phone, or another mechanism. The documentation must also specify the telehealth platform that was used. These are things like Zoom, Microsoft Teams, or other similar programs. The documentation must also include the member's verbal consent to deliver services in this manner. And lastly, the documentation must include the member's phone number that was utilized if that's applicable. I will now turn it over to Carly for more information on telehealth. Thank you.
Thanks, Andrew. All right, we can go into the first slide. Thanks, Amy. So as providers should be aware of by now, on August 26th of this year, in response to the COVID-19 pandemic and the healthcare system's transition to a reliance on telehealth, OMSAS released Medical Assistance Bulletin OMSAS 2109, which was titled Guidelines for the Delivery of Behavioral Health Services Through Telehealth. A hyperlink to that bulletin is provided here on this slide. The purpose of the bulletin was to update the guidelines for the payment of behavioral health services delivered using telehealth technology that was previously issued in OMSAS 2002. So before this, if we can remember back to those times, before the COVID-19 pandemic, telehealth was only allowable in mental health outpatient clinics. It also required a two-way real-time audio and video connection. There was a limitation on who could provide the service via telehealth. Only licensed clinicians were previously able to render services through telehealth. And lastly, members were required to come into a licensed clinic to receive the services, so they could not remain in their home or community. So the updated guidelines from OMSAS 2002 include the following. The new bulletin permits the delivery of services through audio only without video if consistent with Pennsylvania regulations and federal requirements, and more to come on that shortly. The new bulletin expands the use of telehealth service delivery to include drug and alcohol providers that are licensed by DDAP. It expands the use of telehealth to include services that are provided by unlicensed mental health staff who are working through a licensed provider agency, including unlicensed master's level therapist, mental health targeted case managers, certified peer support specialists, certified recovery specialists, and drug and alcohol counselors. It also permits the delivery of services through telehealth in community settings. That means members no longer need to be physically present in a clinic to receive telehealth, but they can receive the services in their home or another location. And lastly, the new bulletin removes the requirement for providers to submit attestations prior to the initiating of the delivery of services by telehealth. So all of these changes are on a permanent basis. So there's still some uncertainty regarding how long the regulatory suspensions will last, but Bulletin 2109 does permit these changes on a permanent basis outside of the regulatory suspensions. You can go to the next slide, please. So now let's talk about those regulatory suspensions. The new telehealth bulletin, its effective date is September 30th of 2021, and that date was intended to coincide with the end of the regulatory suspensions, which up until 2 weeks ago were set to expire on September 30th. Then at the very last minute on September 30th, Pennsylvania House Bill 1861 was signed into law by the governor. A link to that full bill is here on this slide. However, it temporarily extended certain suspensions of regulations and statutes that were issued by agencies under the COVID-19 disaster declaration until March 31st, 2022. Next slide, please. So this slide includes some more information on House Bill 1861. Since we are all involved in and focused on how this impacts the Health Choices program, one of the most important components of the bill was that all regulatory statutes, rules, or regulations that are enforced by the Department of Human Services have been extended. On this slide, you can see here, there's a link to the master list of all suspended regulations. So if you haven't yet reviewed the full list, we would encourage you to do that. In response to House Bill 1861, OMSAS issued an announcement on September 30th. Specifically, they stated that pursuant to Act 63 of 2021, the suspension of various regulatory provisions under the state disaster emergency declaration that are currently in effect and that were set to expire on September 30th are now extended until further notice. So the most important impact of House Bill 1861 and Act 63 is that it supersedes the requirement for providers to submit waivers as initially described in Telehealth Bulletin OMSAS 2109. So outpatient mental health, outpatient DNA, partial providers, you can continue providing only audio-only services if video is not available without a waiver. And case management providers can still accept verbal consent, all without a waiver. The continued suspension of these regulations will remain in effect until further notice. And OMSAS 2109 has been updated to reflect the temporary changes. OMSAS has further stated that additional guidance will be forthcoming for providers who have already submitted waiver requests prior to House Bill 1861 being issued. And if you do have specific questions about the bulletin, we do encourage you to follow up directly with OMSAS and the Bureau of Policy Telehealth Behavioral Health Services resource account. The email address is listed here on this slide, and you can send questions directly to that link. We understand that OMSAS should be issuing an FAQ document in response to provider questions. Next slide, please. So as I just mentioned, OMSAS 2109 was initially released on August 26th. Then on September 30th, after House Bill 1861 was signed into law, OMSAS reissued the bulletin. So this is just a screenshot of the new updated bulletin. You can see that the new issue date is circled here in red, as this version supersedes the version that was first issued on August 26th of 2021. Next slide, please. So the next two slides, I'm just going to show, we're going to show you the difference or the changes between the August 26th version of OMSAS 2109 and the September 30th version. So basically the state just redlined two different sections of the bulletin to remove language that spoke about required waivers. So you can see on the bottom here of this slide, this is the first change they made specific to ICM waivers for verbal consent. You can see that they crossed out that requirement, and they also added a reference to Act 63. And then on the next slide, this is the second change that they made in the September 30th version. They crossed out the waiver requirement for audio-only service delivery in outpatient mental health clinics, DNA clinics, and partial hospitals. We do believe that the state handled it this way and redlined the bulletin so that when the regulatory suspensions eventually end, they will just reissue the bulletin again with the red line edits removed. So these were the only two changes between the August 26th version of the bulletin and the September 30th version. Otherwise, the remaining components of the bulletin are in effect as of September 30th. Next slide, please. So on this slide, we've highlighted a specific section of the updated telehealth bulletin. The section in the bulletin is labeled Access to Services Delivered in Person. The content on this slide is taken directly from the bulletin. The premise here is that members need to have access to in-person services when needed and as clinically appropriate. So unless the provider agency or licensed practitioner have a physical location within 60 minutes or 45 miles from the area being served, the provider, in collaboration with the counties and the behavioral health MCO, would need to apply for an exception waiver. Some frequent questions that we've received from providers about this distance exception include questions from ACT and partial providers who might be utilizing a psychiatrist who is located outside of the area, but the provider still has a physical location in the county. A waiver is not needed in that situation. Again, this is all about the member having access to come into a physical location as needed. So utilizing staff to provide services via telehealth who are outside of this area, the area does not fall into this exception requirement. And again, as a reminder, because the regulatory suspensions were extended, level of care specific regulations such as for act and partial that require a certain amount of face-to-face contact by a physician are currently still waived until March of 2022. So please consult again with that full list of regulatory suspensions, determine if a face-to-face requirement is currently suspended. Next slide, please. So on the next few slides here, I'm going to review some sections of Magellan's FAQ. So we first issued a FAQ document on September 10th, and that was in response to provider questions we had received after the telehealth bulletin was released in August. Then on September 30th, we issued an updated FAQ that included some additional questions and responses, as well as updated answers to the original set of questions. Then a few hours after we had released our September 30th FAQ, the announcement came in regarding House Bill 1861 and the extension of the regulatory suspensions until at least March of 2022. So we are currently working on redlining our September 30th FAQ to align with the extension of the regulatory suspensions. We do hope to have an updated version published next week, and we'll be sending an email communication to the provider network when this is done. You can see here that I did include a link on this slide to our current FAQ. And if you don't receive the email communication for whatever reason, please note that all our FAQ and other telehealth communications are always posted on the provider communications page on our Magellan website. So some of the FAQ responses are still accurate, and I wanted to review some of those now, as these again are frequently asked questions by our provider network. First and foremost, yes, telehealth is still an option for all PA Health Choices services in accordance with Bulletin OMSAS 2109 and the extension of the regulatory suspensions. In terms of contract modifications to provide telehealth permanently, Magellan's not going to be making any contractual changes. So providers should continue to bill place of service code 02 for all services provided via telehealth. And more information is going to be forthcoming regarding the billing of audio only services. Within the state bulletin, you may have seen that it mentions the use of modifier 59 for audio only services. At this point, we will not be able to accommodate the use of that modifier because we do already have some contracts with providers that already have 4 modifiers, and 4 modifiers is the maximum amount that is allowable. So we're discussing this internally and perhaps might be adding a unique place of service code to bill audio only services so that this can be tracked and monitored. But again, no decision on that has been made yet. So please just use 02 for telehealth sessions for place of service code. And then I also wanted to note that for services like case management and family-based that allowed billing for telephone contact prior to COVID, you should not make any changes to your place of service billing. So likely you might have been using place of service 11 or office when billing telephone contact in these services, and you should continue to do that. And then lastly, in terms of allowable platforms per the bulletin, telehealth equipment must meet all state and federal requirements for the transmission or security of health information, and it must comply with HIPAA. So providers should consult their legal counsel or compliance officer for guidance on HIPAA compliant platforms. HRSA has published resources related to HIPAA compliant telehealth platforms, so you can check that out. Unfortunately, Magellan cannot give guidance to providers on what platforms to use or what is HIPAA compliant. But we can tell you that public facing sites such as Facebook Live should never be used for telehealth. All right, next slide, please. So some additional questions and responses that are still relevant. Providers do not need a letter of support from the primary contractor or BIMCO to continue providing telehealth after 9:30 in accordance with OMSAS 2109. A letter of support is only required if you're requesting a waiver of certain requirements or exclusions. But again, because of the extension of the regulatory suspensions, there really should be limited situations that require a waiver. Next, in terms of what level practitioner can provide telehealth services, providers need to maintain compliance with existing minimum qualifications for staff per level of care specific regulations. Per the telehealth bulletin, as I reviewed earlier, provider agencies may use unlicensed staff to provide services using telehealth, but only if they are otherwise qualified to render the service. So again, the minimum qualifications per the level of care specific regulations still apply. Provider agencies should establish and enforce policies for assessing when it is clinically appropriate to deliver services through telehealth. We'll talk a little bit more about clinical appropriateness of using telehealth in a few minutes. Next slide, please. So now I wanted to review encounter form requirements when providing services via telehealth. I wanted to note that there was an update made between our initial September 10th FAQ and our September 30th FAQ specific to encounter form requirements. So our current position is here on this slide. Providers should continue to follow all applicable Pennsylvania Medicaid regulations, bulletins, and Magellan guidelines, which outlines the levels of care that require encounter forms. And signed encounters should still be obtained when face-to-face services are being provided in community-based levels of care. But in terms of signed encounters for telehealth sessions per OMSAS 2109, signatures for service verification may include handwritten or electronic signatures. But in situations where signatures cannot be obtained from the individual served or their caregiver, documentation of verbal consent in the medical record meets the requirement for a signature on an encounter form. It's also important to note that HIPAA does permit electronic signatures, so that would be an acceptable way to obtain a signature if you're able to do that. Over time, Magellan does expect encounter form signatures to be a firm requirement, even when services are rendered via telehealth. We expect OMSAS will be taking this position as well. But again, for the time being, we do support verbal consent on encounter forms following telehealth sessions. Providers who don't have the capabilities for electronic signatures should really begin the process of exploring options related to putting the proper technology or platforms in place. Intent to obtain signature is the critical factor behind the requirement. Additionally, as Patty mentioned earlier in her presentation, providers really should be implementing extra checks and balances and monitoring to provide oversight of service delivery when services are being rendered by telehealth and audio only. So you no longer have those encounter forms to cross-check sessions that are taking place via telehealth or audio only. So that means you have to increase your service verification activity, do more internal auditing and monitoring, just to verify that services took place as billed. You really, again, this is really to protect your agencies and to avoid a large issue down the line if you discover a staff person was billing for services not rendered or falsifying documentation. Next slide, please. So this slide includes some relevant questions and responses specific to the billing of telehealth sessions. Again, I mentioned this a few minutes ago, but Magellan will not be issuing separate billing codes for services provided via telehealth or phone. There's no changes to the procedure code or modifier combinations from your current contracts. Documentation should reflect that telehealth session was provided in accordance with Magellan's guidelines to match all the billing submissions. In terms of billing place of service codes, again, we're requiring that all rendered services through telehealth be billed with place of service 02, and this has been in effect since April 1st of last year. When a non-telehealth service is rendered, please use the appropriate place of service as you would have previously submitted to Magellan. And then lastly, providers who were previously contracted with Magellan for telehealth with a GT modifier prior to COVID-19 will be receiving notification and an updated fee schedule. The GT modifier will no longer be allowable. The state actually recently eliminated this modifier since all services can now be provided via telehealth. All right, next slide, please. Just a couple more questions regarding telehealth billing. First, in terms of billing the rendering site location when providing services via telehealth or phone, when the provider staff might be located in their home or another location, providers should continue to use a rendering site location for which they are contracted and that would have been used if the services were provided in person. If a member's primary insurance plan does not cover telehealth, providers should submit to Magellan as they normally would in another situation where a member's primary insurance is not covering the service. In terms of getting authorizations for members whose primary insurance will not pay for telehealth, again, it's the same process. If a member's primary insurance plan does not cover telehealth as a covered benefit, providers should seek pre-authorization from Medicaid, Magellan, as they normally would. And then if the member has a commercial insurance plan that's covering their telehealth services, will Magellan continue to cover the copay or co-insurance? Yes, this process remains the same for billing us as a secondary benefit. Next slide, please. Andrew reviewed this when he was covering the audit trends for telehealth, but again, just wanted to show this information again because this is really critical. This was taken directly from our current FAQ. These documentation requirements have been in place since March of 2020 and remain unchanged. We first issued these documentation requirements back in April 2nd of 2020 in terms of how providers should document a telehealth session. So nothing has changed there. For each session, every progress note in which telehealth was utilized, you need to indicate, was the session provided by telehealth? Was it phone only? The platform that was used, such as Zoom, must be indicated. The member's verbal consent to receive the session via telehealth must be noted, as well as the phone number that was utilized if applicable. All right, next slide. So we're going to talk more about 2022 audit plans shortly. However, I will tell you that Magellan will be looking to assess provider policies around telehealth in 2022. These policy requirements were all listed in the state's telehealth bulletin. However, we've combined everything into one place on this slide. First and foremost, provider policies and workflows must address how telehealth will be explained to members. It should be reviewed with them the importance of the individual being in a private location, preventing interruptions and distractions such as children or other family members, visitors in the household, and other communication devices. When services are being provided to a child, youth, or young adult, consideration should also be given to how much caregiver involvement might be needed during the appointment. And even if the parent involvement is not needed directly during the session, a parent or caregiver should be available. Additionally, providers using telehealth must have written policies, including a policy on the operation and use of telehealth equipment and all available features. So for example, we're obviously using Zoom today, and many agencies might be using Zoom. And if you weren't aware, there's a lot of safety and other features that can be utilized with Zoom, such as a waiting room, the ability to record sessions with member consent, the ability to mute participants. There's a lot of features that really promote the safety and security of information. So there really should be a policy for staff on the software that you're using for telehealth and all the components that are available. Next, there should be a policy around staff training to ensure telehealth is provided in accordance with the guidance in MA Bulletin OMSAS 2109, as well as any MCO specific requirements. For example, we just shared our documentation requirements for telehealth, so provider staff should be trained on these requirements, and there should be a monitoring process in place to ensure that staff are in compliance. Next, provider agencies should include contingency plans for transmission failure or other technical difficulties that render the service either delayed, interrupted, or undeliverable. So this includes situations where a telehealth session starts, but maybe there's connectivity issues midway through the session. Maybe an individual or provider staff can no longer connect to the telehealth platform that's being used. So how will situations like this be handled? Your policy or procedure should speak to that. The contingency plan should describe how the plan is going to be communicated to the individuals receiving the services, so the members themselves, so they know what to expect when there's a connectivity issue in the middle of a session. There should be a policy that addresses how emergency situations such as risk to harm to self or others when services are being provided via telehealth. We'll talk more about this on the next two slides, but there should also be a process for how appropriateness for telehealth will be determined. Telehealth is not appropriate for every member in every session, so how will provider staff be trained to make that determination? Policies should also include how interpretation services, including sign language interpretation, will be delivered for individuals being served through telehealth. And again, this is not an inclusive list of all the telehealth policies that as an agency you may want to develop, but at a minimum, we would expect that your telehealth policies address the items that you can see here on this slide. All right. The last two slides in this section are related to determining clinical appropriateness for telehealth, including audio-only services. So as I just mentioned, licensed practitioners and provider agencies delivering services through telehealth must have policies that ensure services are delivered only when clinically appropriate to do so. Some of the factors to consider include the preference of the individual served and their legal guardian. This should be given high priority when making a clinical determination of the appropriateness of telehealth. No service should be provided via telehealth when in the best clinical judgment of the licensed practitioner, it is not clinically appropriate. And when it's not clinically appropriate, the provider must offer the services in person. If the individual disagrees with the clinical determination, you can refer that individual to other in-network providers or refer them back to Magellan for assistance. Other factors in the assessment of telehealth appropriateness include whether there's an established relationship with the service provider and the length of time the member has been in treatment, the member's level of acuity, if there is any risk of harm to their self or others, the age of the child or minor, the ability of the individual served to communicate either independently or with some sort of accommodation, if there's any barriers to in-person service delivery for the member. Please remember that telehealth is never provided for the convenience of the provider staff. The member's access to technology should also be a consideration. So if telehealth with an audio and video component is not an option due to the member's access to appropriate technology, audio-only services should not be the immediate default option. A clinical assessment should be made to determine whether audio-only services is appropriate for the member and the situation. The member's access to certain technology shouldn't be the determining factor for how services are delivered if in-person services are more appropriate. Privacy must also be a critical determination for assessing if services can be delivered using telehealth. And lastly, services, question to ask yourselves is, do the services rely on social cueing and fluency, and therefore either in-person or audio and video capabilities might be more appropriate? All right, final slide on the clinical appropriateness of telehealth. As stated in OMSAS 2109, providers and practitioners should carefully consider the clinical appropriateness of telehealth for certain services such as partial hospital, IBHS, family-based services, ACT, or if the member is in a residential or inpatient setting. Included as attachment A in the new telehealth bulletin is a document that's titled Best Practice Guidelines for Telehealth Service Delivery for Children and Youth. This was actually first released by OMSAS as part of Bulletin 2003 that was released in May of 2020. And it was titled Instructions and Guidelines for the Delivery of BHRS and IBHS through Telehealth. So the titles changed within the new telehealth bulletin, but it applies to all services that are rendered to children and adolescents. So there's some best practices within that document based on the age of the child and, a caregiver's involvement in the session. So please make sure you're reviewing that, that guidance in the bulletin. There's additional suggestions for best practices when assessing the appropriateness of telehealth, which include the following. Again, do the caregivers have access to the necessary technology and internet connection? Are there specific protocols that must be implemented in person? Is there a caregiver available if needed? Have the risks versus the benefits of the telehealth session been identified? And will telehealth be utilized as the main method of implementation or as needed or on a temporary basis? I think before moving on, I believe we have a couple questions that have come in.
Yes, we do. I think you actually addressed the first one, but I'm going to read it anyway, just for reiteration. Do we need a modifier on claims to indicate telephone-only sessions?
No, not at this time. More information will be forthcoming regarding the billing of audio only, but for now, if you're doing an audio only session that would have otherwise been conducted in person, just continue billing as you would have previously. And we'll be looking at potentially adding either a place of service code, likely for a unique place of service code for audio only services, but no changes for now.
Thank you. We have another one that came in. Can we get a one-time consent form signed for consent to telehealth, or do they need to consent each session?
They are supposed to consent each session because, again, it's not necessarily appropriate for every session, ongoing. So this is also supported by the OMSAS bulletin that indicates that verbal consent for each session of telehealth should be noted in the documentation.
Thank you, Carly. There's no more questions.
All right, I am going to pass it over to Patty, who's going to talk about our audit plans for next year, as well as review our audit process.
Thank you, Carly. So yes, we will begin talking now about our audit plan for 2022, and also just to reiterate some of our audit process that many of you are familiar with. So right now I'll just spend a few minutes reviewing the different types of audits. First, the routine integrated audit, which is based upon a statistically random sample selected annually from the pool of providers, regardless of the size or type. So it could be a group, it could be an individual, could be an organization. It's all randomly selected. And this includes any combination of a quality, compliance, and a network department. So there's multiple tools that would possibly be sent out. Quality review, a compliance review, and also a network review. A targeted audit, which Magellan will follow up to identify specific concerns. Those concerns could be from a complaint, a whistleblower, anything to that nature. It typically involves our quality review, but it also could be more things included, such as the compliance review and or network, depending what some of the issues or concerns that arise. We also have the implementation oversight audit, and this is conducted on new providers who have recently joined the network, or not necessarily new providers, but also could be providers who have a new service that they are doing for our network. And this includes, again, very similar to the routine integrated, a combination of quality, compliance, and network departments. A follow-up audit is pretty much exactly what it says. It's a follow-up to assess the implementation of a prior action plan. Again, this, depending on what the action plan items were previously, is what departments would be involved in this audit. We also have data mining and compliance audits. So on a quarterly basis, there is a minimum of 3 providers in the top tier for specific services or specific codes that will be selected for a claims audit completed by the SIU. And this is usually Tina Davis or myself is the outreach person who outreaches for the specific information for these audits. However, it could be any one of us auditors doing this data mining. It is strictly based upon data. It is strictly based upon claims and codes that are billed. And then also the SIU conducts a compliance-focused audit. Is a specific subset of providers, and it usually involves a review of the agency's compliance plan, staff interviews, and a small sample of claims audit. Again, this audit is completed by usually myself or Tina Davis. However, any of the SIU auditors could be asking. Next slide, please. So the audit process. Please remember to read the entire audit confirmation letter carefully. I know the audit confirmation letter, there is a lot of information in it, and do that because we want to make sure that you are ready and are prepared for the upcoming audit. So the confirmation letter and all of the tools will be sent out electronically. It is important to send correct member documentation for the audit, such as the intake information, assessments, consents, releases, service plans, treatment plans, progress notes, and encounter forms, just to name a few. So it is important for us to have the information needed in order to conduct the audit. It is also important to have sent the policies, procedures that are applicable. Also sent out with the confirmation letter is our specific audit tools for the audits that are going to be conducted. And they are detailed information. I would highly suggest that you review the audit tools and kind of do your own internal audit with ensuring that the information you are sending to us or have ready for review on site is checked off for those audits on those audit tools. So for routine audits, member names will be sent out approximately like 7 to 10 days a week prior to the audit via secure email. If you have any questions regarding the names that were sent, please contact us in advance. We look at both open and closed records, so if somebody is discharged, it's completely fine. And like I had mentioned earlier, some of the documentation, we review the whole member record, and some of that documentation is what I had mentioned before, such as intake assessments. A lot of times when providers send us the information or have the information ready for us, they always forget to include that intake information because the member could have been having services for a year. But for our QI reviewers, it is important to have that intake information. Also, Magellan also invites our county partners to attend the audits. So we come out as a group, or remotely we do it as a group. So it is important to have space if we are doing on-site, or access if we are doing it remotely for our county partners. Next slide. So the big question is, are you ready? Do you have your policy procedure manual, your compliance plans, your encounter forms, your clinical records, your HR records, including supervision if network is involved in the audits? The start time is usually 9 a.m. However, it is noted in the confirmation letter, pending on the audit and schedules, it may be pushed back a little bit. So again, I cannot reiterate the importance of reading that confirmation letter thoroughly and carefully, and please outreach to us for any questions, concerns that you may have, and also with reviewing the tools in advance. That is one of the reasons why we send them out in advance. If you do have any questions of what is this and what actual document are you looking for this in a certain policy or something, please outreach to us prior to the audit. The auditors do work independently in on-site in a designed space that is comfortable and quiet. Also, it is important if we are doing on-site that there are multiple outlets. Since everything is electronic nowadays, all of our tools are electronic based, so we do need ways to plug in and keep our batteries full. The compliance auditors may also request to interview staff, and that is in our compliance survey that we do conduct for audits. And also, at the end of the audit, we do a informal wrap-up conclusion of some of what we had saw during the audit. Next slide. So what happens after the audit? The initial claims letter and the audit findings report are sent out electronically 30 days following the audit. And the feedback it's organized in is for the audit findings is strengths, recommendations requiring internal action, provider action. Also, there's a section with compliance interviews if they took place. And then there are areas where an action plan is necessary. And that's where it is actually where the provider needs to do its follow-up. Please remember to read that document, the audit findings, very carefully due to there is response due dates within 15 days, calendar days. If you have any questions regarding the findings report, please feel free to outreach to us. We are more than happy to provide any technical assistance or explain things in more detail. And then if there are action plan items, a follow-up audit may be required to look at those implementation of what action plans you are actually putting into place. Next slide. So 2022 audit plan. Our regular provider oversight will continue with the random valid sample selected annually from a pool of providers. Fingers crossed, our goal for 22 is to have on-site audits. Not sure how that's all going to play out, but our fingers are crossed that we'll be back on-site sometime in 2022. We will continue our normal recovery process, which includes appeal documentation within 10 business days after that initial letter. After that initial claims letter is sent, you have 10 business days to send any appeal documentation before the recovery is submitted to our cost containment department. And also, we still take into account, due to the current public health concerns and agency needs, we offer some flexibility with repayments such as payment plan and deferment. Next slide, please. 2022 areas of focus, we will be focusing on IBHS, telehealth, and ASAM alignment. Next slide. So let me first start off by talking about IBHS. Providers have had over a year to adapt since the process of changing from BHRS to IBHS was in effect 1/17/2020. Magellan has collaborative technical assistance forms with providers. A billing guidance is in process of being developed, and contracts have been executed. We also have dedicated resources on Magellan of PA website dedicated for IBHS. Next slide. Telehealth. We will be focusing, this will be a focus for 2022. As Carly had mentioned in earlier presentation with the place of service code 02 for telehealth service. This is very important to use so we can determine if the service was via telehealth or not via telehealth. Also very important is the telehealth documentation standards that Carly had outlined, such as member consent, platform of session, and also our standard documentation standards as outlined in our provider handbook, such as the specific services rendered, the date of service, the names of individuals who rendered the service, the place where the service was rendered, the relationship of service to treatment service plans, the actual time in clock hour services were rendered. And as Carly had mentioned earlier, and to reiterate, it is very important to have the strong policies, procedures for telehealth, including outlining the provider's expectations and their due diligence to perform the best services possible regarding telehealth. These policies, procedures will be reviewed at upcoming audits. We also strongly encourage to increase the member service verification and to vamp up member service verifications and also have a strong policy procedure around member service verification and oversight, especially during telehealth services. And as to reiterate what Carly had mentioned just a few slides earlier, the clinical appropriateness member engagement, it is very important to take this into consideration for telehealth services to ensure that it is working and it is best for our members. Next slide. And finally, for 2022, our plan is the ASAM alignment, which I know is a hot topic and continues to be a hot topic. But on July 1st, 2021, providers were expected to be compliant with specific provisions with the ACAM criteria related to the setting, support systems, staffing, therapy assessments, treatment plan review, and documentation. On June 2021, DDAP issued an important memorandum outlining the procedures for alcohol treatment providers to request an extension beyond the July 1 date. So therefore, you could have had waivers in place or asked the state for. DDAP is looking and approving those requests for the extensions until December 31st, 2021. And also DDAP and Mercer will be issuing an ACAM monitoring tools. We'll be providing trainers for providers. So more to come on this. We are in the same boat as you are with waiting for more information regarding the. At this time, if there are no questions, I'm going to pass it back to Carly for some reminders about confidentialities and consent to treat.
Thanks, Patty. So onto the first slide here, we're going to just talk about some reminders about confidentiality. Confidentiality of all member information is of paramount importance. I think we all are well aware of that at this point. Confidentiality is an ethical obligation of treatment professionals and a legal right for every member, regardless of the source or the format of the information. As a Magellan Network provider, you are responsible for maintaining the confidentiality of all member information. Obviously, I think everyone is familiar with HIPAA, which is a federal law governing what information can be shared and with whom, but there's also state confidentiality laws, as well as state federal substance abuse laws that may be more stringent than HIPAA, and you are always required to follow the most stringent law. Any requirements under federal and state laws regarding confidentiality must be followed regarding the release of information for purposes other than payment, treatment, or healthcare operations without a valid authorization from the member. And providers are responsible for knowing, understanding, and following all applicable laws regarding confidential patient information, including any applicable reporting requirements for child or elder abuse and the common law or statutory duty to warn laws. In addition to providing information, in providing information about confidentiality, we're not furnishing any legal advice. If legal or other professional advice is needed regarding federal or state confidentiality laws, we do advise you to, seek the support of a legal counsel or professional. Next slide, please. So providers are covered entities under HIPAA, just as Magellan is a business associate of a covered entity under HIPAA. So providers must follow all applicable regulations concerning reporting requirements. Providers do not need to report HIPAA violations to Magellan, although some do as a courtesy, but again, it's not a requirement. With that being said, members may file complaints related to their treatment providers protecting their privacy and confidentiality, which we would be required to investigate. We do get quite a few member complaints about privacy and confidentiality on an annual basis. And some of the information we would need to request to review in a complaint investigation around confidentiality includes a written response from the provider. We would ask to review policies and procedures, as well as that member rights were documented and that confirmation that a member received information on their rights. Any completed release forms, which would allow providers to share information with another party, and then possibly progress notes if it's applicable to the complaint. Magellan's consent form to share information or to share a member's protected health information with a third party is referred to as our authorization to use and disclose form. They should be completed in full by the member or the member's representative, although providers may assist members in completing our AUD forms. They should not be filled out by providers. They should be filled out by the member or legal guardians. Providers requesting written information from Magellan related to an individual's past treatment history or other information must have the member, or again, the member's HIPAA representative, complete an AUD. Our AUD forms are easily available on our Magellan of PA website. We have both paper forms that can be printed as well as an online version that members can complete. And just an important reminder, HIPAA releases still require a member or members HIPAA representative. They still require written consent. Verbal consent is not allowable under HIPAA. I think there's been some confusion and a lot of questions during COVID and the disaster declaration where, verbal consent is allowable in a lot of other areas that previously may have required a signature, but specific to HIPAA and the consent to release information, a written signature is still required. And electronic signatures are allowable under HIPAA, so we can accept a consent form or an AUD form signed with an electronic signature. That is allowable. Next slide, please. So some other important reminders about confidentiality. Under the Pennsylvania Health Choices program, the following entities have access to member records: DHS, our county customers, as well as Magellan. This is stated in the regulations as well as your contracts with Magellan. Providers must maintain a member's record in a separate file or a unique record if you're utilizing an EHR. There are minimum record retention clauses in the PA regulations, and there's also some level of care specific bulletins that may outline unique retention requirements. So again, be familiar with the regulations regarding these laws and how long you need to maintain records for individuals. For providers that still do have paper hard copy records, the charts must be kept in a locked file when not in use, and the office that stores the medical records should also be locked. One lock is required. However, we always say that behind two locks is a best practice. Only authorized staff should have access to members' medical records. They should not be open and available to every provider staff person. And this includes EHR systems. So permission levels should be set up in EHR systems to only allow specific information on an as needed basis for that employer to be able to do their jobs, employee to be able to do their jobs. Again, as Magellan stated earlier, we receive a lot of member complaints about privacy. So provider staff should be trained on the protocol for confidentiality, be made aware of their responsibility to maintain the confidentiality of our members, and there should be at least annual training on federal and state confidentiality laws for your staff. Appointment books should also be treated as confidential information and should be kept secured or locked when not in use. And separate entrances and exits, while not required, can always help with maintaining confidentiality. And then last reminder regarding confidentiality: when mailing documents that include PHI, the document should be labeled as confidential. And you should not use any provider identifying information on the return address that indicates that the individual may be receiving behavioral health treatment. All right, finally, last slide in this section, some quick notes and reminders about consent to treat. Per Act 147, children under 14 years of age must have their parent or legal guardian's permission to get mental health care. Children 14 years or older, however, generally do not need their parent or legal guardian's permission to get mental health treatment, but all children, regardless of age, can get assistance for alcohol or drug-related challenges without their parent or legal guardian's permission. Minors between 14 and 17, again, can consent to mental health care, and thus they have the right to decide who can see their records if they are the ones that consented to the treatment. In addition, a parent or legal guardian can also consent for a minor aged 14 to 17. As a general rule, where a minor has the authority to agree to his or her own treatment and the consent of the minor's parent or legal guardian is not needed, the minor controls the release of his or her records regarding treatment. And access and release of record is owned by the consenting party for that particular service. So in the case where a legal guardian consents to a service for their minor child, age 14 to 17, and the minor is not in agreement with the services, the legal guardian controls the release of records for that service. One other reminder for providers related to records is that a consent to treat must be signed and tailored to each service that an individual is receiving at your agency. So for example, if an individual in your program is getting multiple services such as outpatient and case management, there should be a consent for each service. You will notice an asterisk next to the signature here on this slide because, again, as we've discussed, verbal consent is currently allowable when services are being rendered via telehealth. So now I'm going to pass it over to Tina Davis, and she's going to review some other compliance reminders.
Thank you, Carly. We're going to talk about documentation standards and collaborative documentation. Collaborative documentation, also referred to as CD, oftentimes is the time spent working collaboratively with a member on documentation. CD is an interactive approach. The individual must be engaged in the process by providing input and perspective. In 2014, OMSAS published documentation in support of providers using and being able to bill for collaborative documentation. In order for this to be a billable activity, though, certain guidelines must be followed. Here are just a few of them. Providers must have specific policy and procedures in place for using collaborative documentation, which includes training for staff and ongoing supervision that is focused on CD. Providers must define collaborative documentation to the individual so that they are fully aware of the process and may choose to participate or not. If an individual declines, the practitioner may not mandate collaborative documentation. Some members are just not comfortable with somebody typing about them as they are talking to them, say in an outpatient setting. Documentation must clearly indicate that it was written collaboratively with the individual. And collaborative documentation must occur within the scheduled time of the session. For example, if the session was scheduled from 3 to 4 o'clock, the rendering provider can't ask the individual to stay an additional 15 minutes to work on the documentation. The documentation must be completed by 4 p.m. Documentation that does not follow these essential elements is not billable. Next slide, please. Compliance interviews, excuse me. When audits were in person, if you might remember, the auditors would interview staff to gain knowledge of the agency's compliance culture. Once the pandemic hit and audits changed to a virtual nature, we implemented a virtual interview process as well. Surveys are sent out to providers along with confirmation letter and audit tools. 5 to 8 staff of the program being audited are to complete the interview, and they are to be returned to the appropriate claims compliance auditor at least 1 week prior to the audit. Staff completing the interviews should ensure that all sections of the survey are completed. Remember to use non-applicable or N/A for any areas that are not applicable and to not leave anything blank. Responses are for educational purposes only, and staff names are not included in the results summary of the interviews. Next slide, please. It is important for providers to self-audit their programs according to their policies and procedures. When potential fraud, waste, and abuse are found as a result, providers are to report these discrepancies as well as any overpayment to Magellan and to the state. There are several items that need to be included in the report, such as how the issue was initially identified, the type of audit. Was it 100% review? Was it a statistically valid random sample? And how the incident was investigated, the details of that. Also to be included in that summary are the time frame that was audited, how did you determine the audit sample, what the services exactly were that you audited, the results of the audit and the investigation, if an investigation was applicable, and what actions did you take to prevent reoccurrence? Did you educate staff? Did you implement a corrective action plan? Were there any terminations? Oftentimes, an investigation can be involved with just one member or one staff member. And was that member terminated? Did they receive education? What happened? And if there was indeed a termination, please include the date of that termination and any additional information about that staff member, potentially their date of birth, their last phone number and address that you had for them. And once all the information is compiled, such as the summary and the claims information, everything should be emailed to our self-report mailbox at PAHCSSELF report at magellanhealth.com. PACH self-report at magellan.com. Next slide, please. So maintaining active MA enrollment and licensure. Providers are required to maintain both active licensure with the Office of Mental Health and Substance Abuse, or OMSAS, and also the Department of Drug and Alcohol Program, or DDAP, and an active Pennsylvania Medicaid enrollment at the rendering and contracted site location for all levels of care. For the levels of care that do not require licensure, they must otherwise be approved through the state, primary contractors, and Magellan. Please check with your Magellan Network representative to verify licensure requirements. On April 9th, 2020, as a result of the COVID-19 public health emergency, the Department of Human Services issued guidance extending flexibility via a Section 1135 waiver for provider enrollment and revalidation changes. However, on March 23rd of 2021, MA Bulletin 99-21-01 was issued and restores all provider revalidation requirements that were effective June 1st, 2021. So providers must also inform Magellan when there is a change in their licensure status and for other major changes, such as if they move to a new site location. Failure to notify Magellan within the identified timelines may affect your network status or lead to recovery action against claims. Please reference Magellan's April 2021 compliance email blast for more information. I will once again pass to Andrew to provide additional reminders.
Thank you, Tina. I will now go over information regarding data mining audits. On a quarterly basis, a select number of providers will receive a desk audit of an identified level of care or service code. This is a somewhat similar yet slightly scaled down version of a routine audit. The process is laid out in the steps below. Selected providers will receive an email requesting medical records. The aforementioned records will then be sent to the provider or will be sent to the auditor, or access will be provided to the provider's electronic health record. The audit is then conducted. The next step is for an initial claim letter to be emailed to the provider, detailing the results of the data mining audit. Providers will then have 10 business days to review and provide supporting documentation if that step is warranted. If there are no errors or overpayments identified, a final claims letter that states this fact will be sent to the provider and the county as well. If discrepancies are identified, the auditor will then submit the claim information to our cost containment department, and the retraction process will then be implemented. And lastly, an action plan may also be issued to the provider if this is applicable. Magellan also has a member service verification process. Per the Health Choices requirement, members who have received treatment from a Magellan Network enrolled provider will be surveyed to determine the accuracy of the claims that were billed for that member. The process is as follows. On a quarterly basis, 1,818 members will receive a survey in the mail from Magellan. Members are asked to attest to receiving up to 5 services based on paid claims data from the prior month. Magellan will analyze all return surveys and follow up with providers related to any response received that indicates the service was not received. Members can also be contacted if needed for further clarification. If providers may also be required to submit documentation to Magellan to verify that the services did actually take place. Again, if discrepancies are identified, the auditor will submit that information to the cost containment department and retractions will be initiated. Again, also, an action plan may be issued to the provider if warranted by the survey results. Next slide, please. Thank you. As Magellan has a member service verification process, one should be employed on an internal basis by providers as well. This process for the provider should include the following elements. The implementation of both random as well as routine checks via phone, mail, text, or other electronic mechanism. Community-based levels of care should have a weighted distribution. This is to say that service verifications for levels of care like peer support or recovery services should happen on a more regular basis since they are less supervised and clinically based levels of care. In addition, telehealth services should also be subject to more frequent service verifications. Providers should compare the survey responses that they received to the progress notes, encounter form, and submitted claims data. There should be an outlined investigation process for when discrepancies are identified, and quality indicators can be included in this process as well. I'll now turn it over to Holly for information regarding the compliance toolbox and resources. Thank you.
Thanks, Andrew. I'd like to start with talking about our provider training opportunities. Magellan has ongoing training opportunities available for new and existing providers. Some of those topics include network, credentialing, billing, levels of care, authorization procedures, clinical and administrative systems, provider performance and safety indicator monitoring, complaints and grievances, customer service support, member eligibility, fraud, waste, and abuse, documentation requirements, and effective compliance programs. All new providers need to complete the Pennsylvania Health Choices New Provider Training prior to their contract going live. New providers are sent a link to the webinar. All provider staff are expected to complete the training. Once that's done, providers need to return the completed attestation form stating the training was completed by all staff back to Magellan along with the signed contract. The provider contract will not go into effect until Magellan has received a copy of the signed attestation. These trainings are supplements to, they supplement the information provided in the PA Health Choices Provider Handbook Supplement and the Magellan Health National Provider Handbook. At any time, providers can request additional training by reaching out to compliance or SIU staff. Next slide, please. Moving on, the next few slides are resources you can find on the Magellan PA website. First, you can find Magellan's consent to release PHI forms posted under member resources, getting care. As Carly mentioned earlier, consent forms can be filed out electronically by the member or the member's representative and submitted online, or they can be printed out and the member or their representative can complete it before it's mailed or faxed back to Magellan. Both English and Spanish versions of the form are available on the website. Next slide, please. Next up, compliance alerts. There are important topics and reminders that are shared through our monthly compliance email blasts on this page. These are posts on the Magellan of Pennsylvania website under provider provider announcements, which is found on the communications tab. Next slide, please. Fraud, waste, and abuse resources are located under the provider resources tab. This page walks you through what fraud, waste, and abuse is and lists some examples. It's also a great resource to learn more about overpayments, how to prepare for an audit, making a fraud, waste, and abuse referral, and so much more. Next slide, please. Another great resource are the Magellan Provider Handbooks. These outline the policy and procedure requirements for providers serving Magellan members. Go to the communications tab to view the handbooks. From here, you can also review the provider orientation presentation and access the Pennsylvania Health Choices supplements and the required forms. As a side note, please be aware that the Pennsylvania Health Choices Provider Handbook supplement supersedes the Magellan National Provider Handbook when it comes to PA Health Choices members. Next slide, please. Excuse me. Next, we'd like to share with you the provider announcements page found under the communications tab. This page contains a wealth of information, including links to Magellan's provider e-newsletter and recent communications that include training tools and a link to the full program standards and requirements and its appendices posted on the DHS website. Next slide, please. Next, we have a few additional resources we'd like to share with you that are located on external websites separate from Magellan. These include links to information regarding the importance of compliance and documentation published by the Centers for Medicare and Medicaid Services, CMS, a resource guide on measuring compliance program effectiveness, and a website you can go to verify licensures. We would also like to remind providers that it is their responsibility to monitor all federal and state exclusion lists on a monthly basis to ensure their staff are legally able to practice. You can see a list of these exclusion lists on the bottom of this slide. That's it for resources. I'd like to pass it back to Carly for wrapping up.
Thank you, Holly. I wanted to make one correction to something I said earlier. I was told that I was saying Act 63 instead of 73 back when I was talking about the regulatory suspension. So the slide is correct. It does say Act 73 that suspended the regulations until March of 2022. Here you can just see our contact information. Didn't get a lot of questions live during the training today, but you can always feel free to send us questions via email, comments, feedback. We welcome answering questions and providing any additional technical assistance that we can. So please feel free to outreach us directly. In terms of next steps, Amy, if you can move to the next slide. We will be sending a copy of the PowerPoint presentation and Zoom recording to all participants. We do ask that you submit any additional questions to us utilizing the contact information on the previous slide. And please look for upcoming survey to provide feedback and input for future training opportunities. Famous last words: when I don't think the training is going to last 2 hours, it lasted exactly about 2 hours. So I hope the information was helpful and valuable to everyone that participated. We really appreciate your participation and collaboration with us on ensuring compliance in the MA program. So thank you all very much. I hope everyone has a great rest of their Friday and a great weekend, and look for future communications from Magellan. Thank you so much.